Good morning, students. It's Dr. Dushan Kol here. I've joined as a new lecturer in the Department of Oral Maxillofacial Surgery. So today, the topic which we'll be discussing is biopsy and the soft tissue surgeries. So what we do in biopsies and in soft tissue surgeries. So there will be the in this particular topic we have a learning outcomes. Like we have to go for the definition. First will be the definition, then types of the procedure of the biopsy. Then there will be pathologically a request form which we made send to the our pathologist, and then is soft tissue steps and procedures. So what is exactly biopsy? Biopsy is the removal of the tissue for the purpose of microscopic examination and diagnosis. So this biopsy, it came from a Greek word bios, that means life, and opsis means vision. So when we are going for a surgery, if I'm planning for a surgery, so I should know, for example, uh, sometimes we know that it's a squamous cell carcinoma. So, but our treatment will be accordingly, whether it's moderately or it is a well-defined. So, for that particular reason, also we need a histopathological examination. What is it exactly to get a diagnosis? So, there are the classifications of biopsies depending on the techniques employed. One will be the incisional biopsy, one will be the excisional biopsy. Incisional biopsy means that a small part of the tissue we are taking, we're sending it to a pathologist so that he gives us a diagnosis so that our treatment will be planned accordingly. And other is the excisional biopsy. So, why we are doing an incisional biopsy? The main reason is that so we need to plan our treatment, how well treatment will be. For example, if it is a cyst or a ameloblastoma, so I'll do the excision of the whole lesion. Then I have to do a chemical cauterization, like in OKC we do a chemical cauterization and all that. The next thing is what is the materials used. One is the the conventional biopsy and the punch. The clinical timings of the sampling, the intraoperative and extraoperative. So classification of the biopsy. So biopsies we classify into two things. One is the bone biopsy and one is the soft tissue biopsy. In bone biopsy, it is diagnostic and curative, and same it is in soft tissue also diagnostic and curative. Then comes the non-surgical. That's the aspiration one and the cytological one. In non-surgical, if I feel that there is a collection of the fluid, so I'll do aspiration and then I will send it for the histopath examination. So, what is our aim? To provide a suitable representative sample for the pathologist to interpret while minimizing the pre-operative discomfort to the patient, so that my pathologist also gets the right amount of the tissue he needs and there won't be any much discomfort to the patient. So, what are the objectives? To confirm a diagnosis made on the clinical as well as the radiological findings. So, our diagnosis, remember students, our diagnosis is always, it will be first our clinical thing, then it will be our radiological thing, then we'll go for this thing what you call the histopath. So all these three things together, when they combine, then we can reach for a particular diagnosis. That will be our final diagnosis. And then to determine the treatment plan, so whatever my pathologist gives me, yeah, this is this thing or this is moderatively squamous cell carcinoma, it is a well defined, so my treatment plan will be accordingly. And then the valuable self-teaching diagnostic aid. The third point is to the removal of the cancer phobia and as a medical legal record. Remember, students, when you will be going out, so you have to maintain a medical legal record because you don't know what type of patient is coming to you. So it is very good. So tomorrow your patient will come to you. Why, doctor, you did a biopsy for me? I didn't need a biopsy. So that time you can show, see, I have taken this tissue, so I got a biopsy report of this thing. So that's why the biopsy was done. The next is what are the indications of the biopsy? Why we do any lesion that represents for more than 2 weeks with no apparent etiological basis. Then there will be something. The patient will tell you, no, I didn't have a cheek bite or something, but still it is there and it is for more than 2 weeks. Then next is any inflammatory lesion that does not respond to local treatment after 10 to 14 days. For a patient comes to you that I have a I have pain, I have this. They will tell that I have a wound. They won't tell you that it's ulcer. For them, ulcer. They won't tell you ulcer. They don't know this word. That I have a wound. So from last 10 days, 12 days, I am applying this thing. I am applying that thing. But then also it's not healing. Then the third thing is persistent carotid changes in the surface tissue. There will be the the changes in the tissue. What like we are the intraoral thing. It will be little different. The keratosis will be there. And the fourth is any persistent tumor suspected being neoplastic. That by having a look that we I can feel no patient will come to you, doctor, from last 10 days I'm having a wound. Exactly, they will use this wound. So sometimes what will be there, you can feel a cauliflower type of appearance. That is the thing. When we then that time as a surgeon we suspect that something is wrong. We think we feel that it is a malignant lesion. And the fifth part is inflammatory changes of unknown cause that persist for a pretty long time. Then the lesions that interfere with the local functions. See, when a patient, for example, a tongue patient who is having a floor of the mouth or tongue CA. So the movements of this thing, the tongue will be restricted that time. Or example, we have a oral submucous fibrosis. So that time the mouth opening will be reduced. Any then The next is any tissue surgically excised. Then any tissue spontaneously expelled from a body. Materials from a persistent draining sinus whose sources cannot be, we can't identify from where this the sinus is draining. Then a bone lesion not specifically identical by clinical or radiological findings. That time we can go for a bone biopsy. Any lesion that has the characteristics of malignancy. See, as you people, the day by day, once you are out of you pass your fifth year, then so you will get some from 1 year, 2 year, 3 years, you will get experience. Then by even by looking also, you can feel that yeah, I feel that it is a malignancy. It's you, but it won't be always right. So for that, we have to go for a histopath, a biopsy. So what are the indications for the biopsy? So that we should not do any ambiguous lesions caused by recent traumas. See, a trauma, he had a trauma 2 days back, then he comes that doctor, I have a lesion. So that time we won't go, we have to wait for it. Then like I told you before, there'll be these frank malignant lesions. Yeah, we can know, yeah, it's a frank malignant lesion. Then the vascular lesions are there, and proximity of the lesions to the vital structures. That time we should do in a guided way, or we should do that thing in a OT, not in a normal our dental chair. The patient bleeding disorders, we have to check the INR and all that. Then we have to go for it. And post for patients for RT is already done. For those patients, we can't do it and compromise general health of the patient. See, if you feel that patient is diabetic, then patient has what do you call the diabetes is there. And one more thing, patient is complaining of some pain in the left side of the hand or something. So that times patient is a cardiac patient or something, or patient is on ecosprin. Some people they take 150 mg of ecosprin. So for that time, we have to tell them to at least for stop ecosprin for at least for 5 days or 3 days. So next is what are the things? What is the armamentarium? The first thing is the mouth mirror, as you people all know, mouth mirror, probe, and the coloring antiseptic agent. Then is the LA and a syringe. Then is our surgical blade. Number we can go for number 5 blade or something like that. And long pointed surgical scissors. So these are why we are telling a long pointed. So we can get we can get a cut at the end of the tissue which we need to excise. Then the tissue forceps, so that after the excision with one we can take the tissues and put it into the biopsy. I mean into the formalin bottle. Then biopsy punches and the bone buzz, normal bone buzz, what we're using for impaction or something, is the same buzz. Periosteal elevator, that is for elevating the flap if you are going for a bone biopsy. And then the chisel, sometimes we do with the chisel and mallet. We If we want to do a bone biopsy, we'll do it with a chisel and mallet. And then a curette. Then suture material, needle holders, sponges, and wide mouth bottles which contains 10% of the formalin. See, when I told you about the suture materials, if we feel that when we are suturing we feel that the bleeding is more, so we should never go too deep after doing after doing a biopsy, and that too. And if we suspect that this particular thing is a C or something, what happens when we are taking a suture, when suturing, we are making the cancer cells to proliferate into more deeper layers. That thing should not be done. The sutures should not be. I can tell you, sutures should be superficial, not that totally superficial in the mucus or something, but it should not be deep. Please remember all this thing. Okay. So then the types of the biopsies. Incisional biopsy, yeah, I feel that, yeah, it's the patient came to me with CA, so I'll tell him that I'll take a small part of this thing and I will go for a histopath, and then accordingly I will decide. That is the incisional biopsy. Small part we'll take once we get the diagnosis, then we'll plan for the excision of the whole lesion. Then is the excisional biopsy, where the whole of the part of the whole part is excised. Then it's explorative. Then we do a curettage, like in the cysts or some things. We'll do a full curettage. We'll do, and we'll send it for the histopath. Then there is the punch biopsy. That particular area will go for a punch. There are different punches of different sizes. We'll go. Then there is a it's a shave biopsy, we call it, or a brush biopsy. Then is a fine needle, what you call FNAC. Sorry, fine needle cutting biopsy, not FNAC. Then is electrosurgery, or with the biopsies which we do with the lasers. Then is the core biopsy. Then is the bone biopsy, bone marrow biopsy. See, these bone marrow biopsies, as a dentist, as a oral surgeon, we don't go for bone marrow biopsies. It is the general surgeons and all that, they go for the bone biopsies. Then is the unplanned biopsies. So, what is incisional biopsy? It is a biopsy which we do to take a particular tissue, and then we send it for the histopath examination. So, to get a diagnosis, so that we can treat or plan. It's a So, what will be the definition? It's a biopsy samples only a representative part of the lesion, not the full lesion. So, what will be the indication? Indication, it should be a size around 1 centimeters. When management can be planned only after diagnosis, when other treatment modalities are not planned, when excisional is contraindicated due to hazardous location of the lesion, when it's located near to the facial artery and like that. See, when we are doing the incisional biopsy, some people they tell that we can take 1 centimeter, less than 1 centimeter. It depends upon. It's not that our pathologist is wrong. It depends on the microtome he is using. So when the last where I was working, I used to give him around zero point 0.5 to zero point 0.6 this thing of this, and he used to give me. It depends upon the microtome. So then the principle is the representative of the lesion biopsy area with the maximal tissue changes. Wherever you find that, this particular part, there is a lesion, I can with the normal tissue I can really differentiate. Yeah, that is the particular that area we need to do it. Okay. Deep and narrow rather than your biopsy should be always deep and narrow rather than being a shallow or broad. We don't need that much. We are not doing an excisional biopsy here. When the lesion is extensive or non-homogeneous, multiple lesions biopsies are advocated. So next comes the excisional biopsy. Excisional biopsy, when the whole of the lesion we excise. We won't keep anything. So whole of the lesion will excise and we'll send it for the histopath examination. So what will be the definition? It is the removal of the entire lesion during the surgical diagnostic procedure. So it will be the removal in the total. We won't be keeping any other that particular tissues left in that. It will be in a total form. What we call it in a surgical removal in total. A parameter of the surrounding normal tissue is always excised with the when we are doing biopsies, so that our pathologist he can differentiate between this is the normal tissue and this is the tissue which is diseased, or which or any other pathology is there. Indication is it should be more than no, 1 centimeter, or it depends upon the lesion. Acha. And it can be benign on clinical. It might appear that it is benign on clinical examination, but it can be in a malignant. Acha. location such that it can be removed with the margin of the normal tissue and the wounds closed primarily. So I told you why we are removing with the normal tissue and not that particular, because we need to give, like we are doing in CA, we need to give a clearance of 1 centimeter or point. Mostly I give clearance of 1.5 centimeters. Ideally they tell 1 centimeter, but we can give a clearance up to 1 centimeters or 1.5 or 2 centimeters. 1.5 is the best. Even I do it 1.5, and I do get best results by doing 1.5. So I don't come, the patient will again will be coming after 6 or 7 months that I have developed this thing again. Then the principle same as incisional biopsy, it can be elliptical or V shape, and the margins of the normal. That is the punch biopsy, usually a variant of the incisional biopsy which uses specifically designed punches for the, that are the exact, that's punches are there for the removal of this tissue. We use that punch, we do it, and it comes out, and we send it for the histopathical. And the instruments what we use, the surgical blade and a plastic handle. Then is the blade available in a diameter of 1 to 2 mm or something, and commonly uses 6 mm. So what is the technique by which we do it? The punches held perpendicular. Remember this thing, it should be always held perpendicular to the skin and gently rotated with a firm download pressure till a subcutaneous fat or a deep, if we require a deep, we can go. But we should be very careful that we should not excise the, for example, if you're doing for what do you call that, for a buccal mucosa. So we have to do it in a such a way, in a perpendicular way, that we are not taking the full skin out. So there should be a gentle rotation. Then only you will come to know how I have reached the fat tissue. So I won't go below that. Otherwise, we'll touch the skin. Then the punches is left. A column of the tissue comes along with it. It is a just hole, and you can feel that there's a tissue is inside it. The inside tissue is released using a scalpel blade or a forceps or a tweezer. You can take it out, but very gently. There is the bone biopsies. There are different for the, what do you call, in oral surgery also we do it. One is the indirect technique. In indirect technique, there's a require the raising of a flap, a chisel or a mallet, or we can use it with the burrs. Some people prefer a chisel or a mallet, and some prefer nowadays mostly we do it with the burrs. It is composed of a hollow cylinder with a cutting edge that allows the harvesting of the bone cylinders of different sizes. So different, and always do one thing. If we have a big lesion, for example, take one or two the specimens. That will be much helpful for the our pathologists also. Then is the exfoliative cytology. Is a study of the cells which exfoliate or abrade from the body of the surface. So that particular that that thing we send it for the histopath examination. Then is definition. The exfoliative cytology is a microscopic examination of the shed or discamated cells from the epithelial surface, usually the mucous membranes. It also includes the study of those cells that have been collected by scraping the tissue surfaces or collected from the body fluids such as sputum or saliva. Then is FNAC. FN is a standard disposable. We use 21 to 25 gauge of needles with 10 ml or 20 ml of syringe. If we feel that it is more, mostly 10 ml and 20 ml is more than enough. Then what is the advantage? It has excellent patient compliance. Patient won't have any surgical wound or something like that. Can be readily repeated, and if you feel that no, this one, so we can readily. So we are not excising any tissue. The next is minimal or no complications such as pain or bleeding or something like that. What happens in the incisional biopsy? Disadvantage is the only thing is that it sometimes it won't give us that adequate amount of cells which we require, and sometimes the results can be false. Then is the lasers. Nowadays, as the technology is there, so we can use lasers also. If a laser is used for incisional or excisional biopsy, a zero point 0.5 mm margin should be maintained between the cut and the representative area to be sampled. 0.5, or yeah, not more than that. Then what is the advantage? Minimal intraoperative hemorrhages will be there. Post-operative discomfort, there's no post-operative discomfort as there is no bleeding and all that. Disadvantage. produces the thermal artificial the changes, the artifacts that thing. Then it's the impigmentation of the specimen and generation of the excessive heat, the heat that is generate with adequate removal of the layer. So everywhere there are recent advantages. So what are the recent advantages? I'll tell you. Automation of the cytological screening, uses of powerful computers. What are they use the dyes and all that. Then cytoanalysis based on the measurement of the various cellular parameters. Then is the image analysis, quantitative analysis of the various cell components, so that we'll come to know that what is the cytoplasm this thing ratio and all that, the nucleus and that ratio. Then is flow cytometry, can measure multiple physical characteristics of the cell suspended in a solution at the rate solute at the rate of 3000 to 5000 cells per second. Thank you, students. Any other doubts or anything, please let me know. You are always free to come to me. Okay, thank you.